inviting me, as well as the organizers from DAVA. I think this is a great venue and a great meeting. This changer sort of reminds me of a joke my wife played on me one night. I fell asleep with the channel changer in my hand, and she grabbed the second one and kept on changing the channels as I was napping. It was a very, very strange situation. So my task this morning is to talk about immunotherapy for urothelial carcinomas, and these are my disclosures. I'll also disclose that I root for the Mets, the Jets, and the Yankees. I shouldn't say Mets these days. We've come a long way, and this is Alan Yagoda. Some of you in the room may have remembered him. He really was one of the most colorful characters in GU oncology for a number of years. He invented the MVAC regimen. Those data were published in the 1980s, and I always put this up to remind myself of how far we've come, because Alan was really an inspiration to me, but also from the time that he published the MVAC data until recently, when we started publishing the data with the checkpoint inhibitors, we really didn't have a treatment that improved survival in bladder cancer. And that was really the subject of a lot of disappointment and disappointing trials. So this is the landscape for the disease. We know that about 70 to 80% of bladder cancers are non-muscle invasive, and these are treated with TURBTs and subsequently intravesical BCG. Once a patient fails BCG, there is a standard of care which really nobody uses. It's an anthracycline, and this is an immune-mediated process. And this is one of the things that led us to looking at checkpoint inhibitors in metastatic disease, because we did have success in early bladder cancer. Once the disease invades the muscle, the whole game changes. There are vascular channels, there are blood vessels where the tumor cells can then disseminate, and we considered the treatment of bladder cancer at that point to be systemic, and neoadjuvant chemotherapy plus radical cystectomy for these muscle-invasive patients is standard of care. I'm going to review the first-line data briefly to give us perspective, but GEM-CIS and MVAC are considered equivalent first-line treatments, and then up until recently, we didn't have a second-line treatment that improved survival. And now we have a number of agents that are showing promise. So this is the long-term follow-up data from MVAC that was published by Scott Saxman in the JCO in 1997. And what he found was that you did see survival benefits, but look at the 3- and 6-year survivals of combination chemotherapy. 17 patients out of 133 alive at 3 years, and then 9 patients at 6. Very, very disappointing. So you get rapid responses with this disease. It is chemosensitive, but unfortunately the durability of the response is not good. And in fact, about 5% of patients are alive, usually at 5 years, with systemic chemotherapy. So how do we try to improve upon the regimen? Well, we increase the dose, and dose-dense MVAC has been evaluated in a randomized trial in patients with metastatic urothelial carcinoma. Basically, what you're doing is you're giving the 4 drugs every other week, rather than giving intermediate doses of methotrexate and vinblastine on days 14 and days 21. And this increases the dose. It's actually better tolerated than the standard dose of MVAC. And these are the data. You see that there's much less neutropenia, less neutropenic fevers with high-dose MVAC, but no difference in survival compared to standard dose. The same thing occurs with gemcitabine and cisplatin. This is a standard of care. Median survival is about 15 months. It's not exactly an equivalence trial. In fact, when this was first designed, Lilly did not want to move forth with another 500 patients to make it equivalence. So there is the possibility that MVAC is better than GEM-CIS, but nonetheless about a 15-month survival. When you add paclitaxel, there's a 14% reduction in the risk of death, but it's not significant. So adding more chemotherapy does not improve survival. And then in the second-line setting, bladder cancer also has a separate series of problems that we also must address. As we know, cisplatin is standard of care for platinum-eligible patients, but there are patients who can't receive cisplatin. And these are patients with renal insufficiency, cardiac dysfunction, poor performance status, and right now, up until the approval of the checkpoints, there was no consistent standard which was used. And the treatment goals shift to palliation in these patients, and now we're using immunotherapy as frontline treatment. So the problem had been, what do you do when a patient fails platinum-based chemotherapy? And the survivals have been fairly dismal. We look at paclitaxel and docetaxel, we're seeing survivals of 7 to 9 months, response rates of about 10% overall. So these patients unfortunately died rapidly from their disease, and it was often a poor quality of life afterwards. So checkpoints. We know that PD-1, PD-L1s are approved in urothelial carcinoma. These markers are expressed in urothelial cancer. We know that bladder cancers have a high mutational rate. So as in lung cancer, it made sense to look at the checkpoint inhibitors in this particular situation. So this is the landscape of the approvals for urothelial carcinoma. 2 are approved for platinum-ineligible patients. That's atezolizumab and pembrolizumab. And then there are 5 agents that are approved in second line for patients who fail platinum-based therapy. That includes atezolizumab, as well as pembrolizumab, and nivolumab, durvalumab, and avelumab. There are 2 things that distinguish these agents, but they all, in my mind, are the same. There's only one with a randomized phase 3 trial, and there's also one that has an antibody-dependent cytotoxicity, which is not seen with the other agents. But aside from that, in my mind, they're all about the same in terms of their response rate and survival. So let's go through the first-line cisplatin-ineligible patients. In 2017, atezolizumab was approved, followed 1 month later by pembrolizumab. And this is for those patients, again, with locally advanced or metastatic urothelial carcinoma. So the atezolizumab data came out of IMvigor210, which was a 2-armed or 2-tiered study that looked at 2 different cohorts. In cohort 1, these were the cisplatin-ineligible patients, as I mentioned by the criteria before, and they received 1,200 milligrams of atezolizumab every 3 weeks, and they were also evaluated for PD-L1 staining. What did I do here? So it was basically, again, the same criteria I mentioned before: renal impairment, hearing loss, peripheral neuropathy, or an ECOG of 2. So this is the response and survival data from this study: 23% objective response rate. And this is where it now starts getting very, very confusing. If we look at the survivals based upon PD-L1 staining, and this is using the SP142 assay, and I'll talk more in detail about that a little bit later, but this is an assay that basically measures the staining or the immunoreactivity on the immune cells, not really good for the tumor cells. We see there really isn't any difference if you are PD-L1 positive or PD-L1 negative. You all seem to have about the same survival across the board. And Keynote 52 looked at pembrolizumab, a PD-1 inhibitor, in a very, very similar group of patients, slightly larger trial, 350 patients, no prior chemotherapy, and this one included those patients with New York Heart Association Class 3. Pembro was given every 3 weeks at 200 milligrams, and again, the primary endpoints, these were accelerated approvals based upon objective response rate. And a very, very similar objective response rate, with 29% of patients having an objective response and 7% of patients having complete response. So as you all probably have heard, there's been an FDA alert that's come out for patients who are platinum or frontline patients. So carboplatin-based chemotherapy was the default standard of care in the past, and then patients received pembrolizumab and they went on to a taxane. Now what we're doing is giving pembrolizumab and atezolizumab and then giving carboplatin-based chemotherapy in the second line, and they go on to a taxane. You look at comorbidities, we didn't have any validated biomarkers, but now the FDA is also mandating that we go forth with PD-L1 staining. And this is because of some data that was seen in some randomized trials. So this is the comparative data with gemcarbo, atezolizumab, and pembrolizumab. As we see here, the response rates are about 41% for gemcarbo, atezolizumab 23%, 24% for pembro, about a 16-month survival for atezolizumab, not reported yet for pembro. And the progression-free survivals, something we really, I think, should ignore with immune therapy, seem to be somewhat better with chemo, as one would expect. So this is the FDA alert. There are 2 ongoing trials that are looking at upfront checkpoint inhibition therapy compared to combination therapy with chemotherapy. And the monotherapy arms, in those patients with a low PD-L1 status, they had decreased survival. So both trials have stopped enrolling patients whose tumors are PD-L1 low or PD-L1 negative. And the FDA has put out an alert that you should test all of your patients for PD-L1 prior to putting them on for checkpoints as front line. If they're PD-L1 low, in my mind, they should go on a clinical trial or carboplatin-based chemotherapy. And if they're high, it's appropriate to give either one of these 2 checkpoints. I'm going to go rapidly through this data because basically, in my mind, as I said before, these are very, very similar drugs with very, very similar response rates. So in Vigor 210 in cohort number 2, these are the platinum experienced patients, 310 patients overall. And again, they received the same dose of atezolizumab. And here, this is where we start getting all confused about PD-L1 staining. We see that there is a distribution based upon PD-L1 status. The highs have a better survival and response to 12-month survival is 48% versus 29% for those patients who are PD-L1 low. And again, I have no explanation as to why we see the difference in one and on the other. Now, we do have long-term survival data with atezolizumab, and this is from our phase 1 experience. We published this in JAMA back in January. This is a 92-patient experience, and 72% had more than 2 prior systemic chemotherapies. About half of these patients were PD-L1 high. As you see from the swim lane plot, there are patients who are still, at 2 years follow-up, that are still responding to their initial treatment. And this is the overall survival by PD-L1 status. Again, it distributes out the same way that we talked about before with the phase 2 data. Now, interestingly, we can begin to predict which patients by clinical characteristics are going to do well with checkpoint therapy. As one would expect, the patients with hepatic metastases do much worse overall based upon this forest plot. Those with nodal disease only do better. Those with good performance status do better. So this is one way that we may want to select our patients for clinical trials to give more aggressive immune therapy or combination therapy. These drugs are well tolerated over a long period of time. In fact, the majority of adverse events occur early in these patients, and you generally don't see treatment-related adverse events more than 2 years out, and actually more than 1 year out from these overall toxicity data. Now, phase 3 trials in Vigor 211, randomized trial in patients with second-line urothelial carcinoma done predominantly in Europe, but also the United States. This was a biomarker-driven trial, and this was looking at both PD-L1 positive and negative patients. The primary endpoint was overall survival in the patients who had high PD-L1 expression, and then they looked at a more broader level expression than intent to treat. Secondary endpoints are PFS, objective response rate, and duration of response. So again, this is a tier based upon the primary endpoints, IC23, 123, and then ITT. So when you analyze the first tier, which is the 2-3s, you see no significant difference in survival. There are a lot of reasons or explanations for this. And one, which I think is particularly important, is PD-L1 expression is not only predictive, but it's prognostic, and that may have been what selected this out. Also, the chemotherapy arm did somewhat better than what you would have expected. Who would have ever thought that vinflunine would have a survival of about 10 months? Predominantly, vinflunine was given in the experimental arm. You didn't see the difference when you add the IC1s. However, if they did it on an intent to treat basis, it would have been a positive trial. But because of the trial design, you could not state that. It had to be first the 2s and 3s, and then the 1, 2s, and 3s for this to be all patients. Chemotherapy type, it does seem to be significantly different compared to taxanes, but this is a subgroup analysis, and it's again small. So nivolumab has been evaluated in patients with metastatic urothelial carcinoma, 3 milligrams per kg every other week, 270 patients in the large trial, median survival of 8.74 months overall, and again, not terribly different than atezolizumab or pembro. Phase 1 trials are hard to compare because, again, these have different patient characteristics, so you can't compare one to the other. Durvalumab has been evaluated at 10 milligrams per kilogram every other week in a phase 1 trial in the urothelial cohort. Again, we're seeing objective response rates of about 18%, complete response rates of 4%, slightly higher survival, 18.2 months, and a PFS of 1.5 months. The survival benefits being driven by the durability of the response. Durvalumab, this is actually a trial that we're all waiting for. I'm sorry this didn't come out better, but this is the Danube study. I'll disclose I'm one of the on the steering committee for this. But Danube is looking at comparing chemotherapy or dealer's choice chemo, which is either Carbogem or Cisgem, to single-agent durvalumab or durvalumab plus tremelimumab. So it's going to answer the question, is chemotherapy similar to or better than immune therapy or vice versa in this particular setting? And the trial is fully accrued, and I hope within the next year we'll have the final answer to that question. Avelumab has been also evaluated in patients with metastatic urothelial carcinoma. Very, very similar data, again, to what we saw before. No correlation with PD-L1 status, median survival about 7 months. And then finally, the one trial that did turn out to be positive in the phase 3 setting was Keynote-45, which evaluated pembrolizumab at 200 milligrams every 3 weeks for 2 years and compared that to dealer's choice chemotherapy. This trial did have a positive benefit in terms of survival, about 10.3 months for pembro versus 7.4 months for chemotherapy, and there was no difference really in progression-free survival. So future directions, we're looking at combinations. The Danube trial may help answer that question. There are trials that are looking at ipilimumab combined with nivolumab. There's one that's been looked at giving ipilimumab at the time of progression on nivolumab, as one would expect, not really a huge survival benefit, a huge response benefit. This is a small number of patients. This was presented at ASCO about a year or two ago. Unfortunately, some of these drugs have already bit the dust. Epacadostat, which is an IDO inhibitor, was being evaluated in head and neck cancer and lung cancer. It looked promising in a phase 2 trial in urothelial carcinoma. This was going forth in a randomized trial in frontline patients as well as in second-line patients, but these trials have stopped, and it will be interesting to see what the data will turn out to be from at least an analysis of the patients who recruited on this particular trial. I briefly mentioned biomarkers in this disease. It's difficult to interpret, but one of the things that we have seen is that PD-L1 staining does seem to go along with a higher response rate. It may be linked to survival, but there are different assays, and we need more biomarkers for this disease. So these are the 3 main assays. The SP142, which is used with atezolizumab, is an assay that recognizes immune staining of PD-L1. The SP263 and the 22C3 will look both at the tumor cells as well as the immune cells. And right there, you've got a big difference in how these antibodies may be used. And they also may have different associations with different drugs. In fact, David Rim at our institution in lung cancer has looked at all of these antibodies and has found a 63% concordance between the 3 antibodies of finding PD-L1 positivity. So in my mind, that's not good enough. We need better markers than that to tell us what to do. Now, part of this may be related to mutational load. We know that bladder cancer is in the right portion of the spectrum, along with lung cancer and melanoma as having a high mutational load and a high mutational rate. And so we've looked at some of the, Jonathan Rosenberg has looked at some of the atezolizumab data in terms of basal versus luminal bladder cancer, as well as those patients who have high levels of mutational load. So if you start looking at the responders in basal versus luminal, the ones that seem to do the best with atezolizumab are the luminal type 2s. If you start adding on mutational load, you can further separate out these curves and determine who's going to do better. As one would expect, the high mutational loads will do better than those patients who have lower mutational loads. And again, this is what we think is the immune phenotype that it works the best in, the luminal type 2s. And this may be related to this issue of the immune desert. The luminal ones really do not have T cells or have any sort of immune infiltration. The luminal type 2s are inflamed, and this is where we see our increased responses. The basals are the ones that have the immune cells present, but they have also high levels of T effector cells and also high stromal gene expression. These may inhibit T cell function, and then our goal is to figure out how we can turn these on. Of course, also with luminal ones, how we can move immune cells into those particular areas. The data is a little bit different with nivolumab. It does seem that the luminal type 1s also do well, and again, this may be one of the ways we differentiate PD-1s from PD-L1s. So in conclusion, checkpoint inhibition therapy demonstrates significant anti-tumor activity in advanced urothelial carcinoma as initial therapy in cisplatin-ineligible patients and in patients treated with prior cisplatin-based chemotherapy. Our response rates are about 25%, so that means we need to do better in this disease. And Right now, there are a variety of different approaches about augmenting the immune system. There are newer cytotoxic agents as well as targeted agents that are now moving into this particular area, which we're very, very excited about, but are beyond the scope of the immune therapy talk. We need to also look at immune therapy at earlier stages of disease. We're looking at this as adjuvant therapy post-cystectomy, and also there are neoadjuvant trials that are now being designed. But what we really need is a good marker study. In all those studies that I talked about before, this was done in archival tissue. There really has been a lack of information about sequentially derived biopsies from the same source that are looked at with the same methods or the same different molecular methods, as well as imaging techniques. That's the other thing we need as well, because we know this disease is heterogeneous, and my colleague at Yale, Roy Herbst, will show us slides of a lymph node where you have vastly different staining of PD-L1 in one portion node versus the other. So I think that that's really going to be the key. Understanding this molecularly, how can we use this in all of our patients? And I think we've got an exciting future ahead in this disease. So I thank you for your attention, and then we'll move on to our next talk. I think we'll do questions.